خلاص جاهزة يا ياسمين؟
Dr. Yasmine is present.
This is the next session, will be started now. Dr. Muhammad Sarwat will present the first lecture.
Bismillah ar-Rahman ar-Rahim. Our first lecture is disorders of sex development, how to approach. هتكلمنا عنها الدكتورة ياسمين عصام. اتفضلي يا دكتورة ياسمين.
Disorders of sex development and how to approach. Disorders of sex development, formerly termed as ambiguous genitalia, are a group of conditions where the external genitalia appear abnormal. It includes a wide range of rare congenital conditions among the chromosomal, gonadal, and phenotypic characteristics that define sexual differentiation. It represents a true medical and social emergency that needs a multidisciplinary team approach for diagnosis and management. The estimated prevalence is about 0.18%, and it's higher in the community with increased rate of positive consanguinity. From the early beginning in the embryology, the Y chromosome, it's called the testis determining factor. It's the one who is responsible to direct the primordial gonads to be differentiated not to ovaries and instead to testis. The testis is formed from Sertoli cells and Leydig cells, with the Sertoli cells forming the anti-Mullerian hormone and the Leydig cells producing the testosterone. The anti-Mullerian hormone is responsible about the Mullerian duct regression, and the testosterone is responsible about the Wolffian duct development, like epididymis vas deferens and semital vesicles, and it is converted to dihydrotestosterone, which is responsible about the formation of the penis, scrotum, and prostate. This is a schematic view for the undifferentiated genitalia early in the embryology, and then at 12 weeks of the fetal age, differentiating it into female and male external genitalia according to the presence of the Y chromosome, and then later in the 36 weeks of gestational age. The current method of diagnostic DSD include the clinical examination, laboratory tests, and radiological imaging. With the clinical examination include physical examination, laboratory tests for testing the hormonal levels and identify chromosomal abnormalities, and the radiological imaging for evaluating of the genitourinary tract and the adjacent organs, and the most important of them is the suprarenal glands. The first step in the management of the DSD in is sex assignment, and this is done by finding the genotype, the presence, location, and appearance of reproductive organs, the potential for fertility, and cultural backgrounds of this community. With our concern as a radiologist is the presence, location, and appearance of reproductive organs. And this leads to the next step of management, which might be surgical, hormonal therapy, or no intervention at all. The genital anatomy is very well demonstrated by magnetic resonance imaging because it has an unsurpassed soft tissue contrast and multiplanar capabilities with no radiation exposure. However, ultrasonography with different approaches like the transabdominal, transrectal, and transperineal is still the primary modality for demonstrating the internal organs. The retrograde genitourography is used to assess the urethra, vagina, uterus, and fistulous communication or complex tract. DSD classification, it has an old classification and a new one. The old classification as the female pseudohermaphrodism, it's called now 46XX DSD, maternal virilization syndrome. The male pseudohermaphrodism is now called the 46XY DSD. The true hermaphrodism with the patient having both the ovarian and testicular tissue is now called ovotesticular DSD. And the gonadal dysgenesis, which was classified as mixed gonadal dysgenesis, now called partial gonadal dysgenesis. The pure gonadal dysgenesis and complete gonadal dysgenesis, now classified as complete gonadal dysgenesis. This is an algorithm published by Moshiri et al. In Radiographics 2012, and I found it very helpful in reaching the diagnosis of such cases because we don't encounter them so much, so we always need an algorithm to go for to remind us how to reach a proper diagnosis, which is very important for the management. This is an overlook for the algorithm for us as a radiologist. We always have to ask ourselves when we encounter a case either by MRI or ultrasound. 3 questions to be asked. The first of one, if we have palpable gonads, and this means that we have a palpable gonads or a proper testicular tissue, the presence of the uterus, either well-formed or even with variable degrees of dysgenesis, and the presence of other gonads like streak gonads or testes or ovotestes or ovaries. We always have to find answers for these 3 questions to reach a diagnosis. The first question is always, is there a palpable gonad? And another, it doesn't have to be palpable, but do we have a proper testicular tissues? The answer can be yes. It can be we have only one, or we have no testicular tissues at all. If the answer is yes, we will move to the second question to find in the algorithm and it is there a uterus? No or yes. If there is no uterus, and we ask the first question that we have yes, proper testicular tissue, either palpable or not, with no uterus and no ovaries, so the answer to our diagnosis is various degree of 46 XYZSD. If we have uterus or rudimentary uterus, so we have to look for other gonads like testes or ovotestes. This is called ovotesticular DSD. This is a case, 20 years old female with primary amenorrhea. This is the axial T2 weighted images in the MRI and the diffusion. We can find here 2 palpable testes in the inguinal region, and the upper cut shows no uterus and no ovaries. This is the sagittal view showing us the hypertrophyte clitoris. So this takes us to the part of the algorithm that we have 2 palpable gonads, we have no uterus, and we have no ovaries, so the answer to diagnosis is 46 XYZSD androgen insensitivity syndrome. If the answer of the first question is that we have a 1 palpable or 1 proper testicular tissue, so we will ask for the second question, do we have a uterus, no or yes? If there is no uterus and we have no ovaries, again we have a various degree of 46 XYZSD. But if we have a uterus or rudimentary uterus, we look for the other gonads. If we have a streak gonad, this is diagnosed as partial gonadal dysgenesis. If we have testes or ovotestes, this is called ovotesticular DSD. This is a 14-year-old female with primary amenorrhea. Here the axial T2 weighted image shows us testicular tissue, a proper testicular tissue on the left side, and we can see it in the sagittal view of the T2 weighted image and on the diffusion weighted images. And on the other side, we can see a streak gonad. Here in the sagittal view, we can see the hypertrophyte clitoris, and here we can see a rudimentary uterus. So this takes us to part of the algorithm when we have 1 palpable or 1 proper testicular tissue. Yes, we have a dysplastic uterus, and the other gonad is streak gonad, so the final diagnosis is partial gonadal dysgenesis. If the answer of our first question is that no, we don't have palpable gonads or proper testicular tissue, so we have to jump for the second question, do we have a uterus? If the answer is no and we have no ovaries, this is again various degree of 46 XYZSD. If the answer is yes and we have streak gonads instead, this is called complete gonadal dysgenesis. If we have testes or ovotestes, this is called ovotesticular DSD. And if we have ovaries, this is called 46XXTSD, which is a maternal virilization syndrome. This is an 18-year-old female with primary amenorrhea. We can see here on the right side a testicular, not very proper testicular tissue, but it is like an ovotesticular texture. On a higher level, we can see ovary on the same side. This is on the coronal image. We can see the ovotesticular tissues down, and above it the ovarian tissue. And on the other side, we don't have any gonads, which is a streak gonad. On the sagittal view, here we can see a rudimentary dysplastic uterus or uterine body, and we don't have hypertrophied clitoris. This takes us to algorithm where we have no proper testicular tissue. Yes, we have a uterus and we have testes or ovotestes, and this is the diagnosis of ovotesticular DSD. This is the second patient. It's a 17-year-old female with pelvic pain. Ultrasound diagnosis was ovarian tissue. By the MRI, here we can see a dysplastic ovotesticular tissue on the left side. On a higher level, we can see an ovary, and on the right adenexa, we can see the neoplastic lesion. We have a well-formed uterus, and we have hypertrophied clitoris. This takes us to the part of the algorithm when we have no proper testicular tissue or palpable gonads. Yes, we have uterus, and yes, we have testes or ovotestes. So again, its diagnosis is ovotesticular DSD and complicated by gonadoblastoma. This is another case. Unfortunately, she passed away before she do MRI, but she was referred to us first to do ultrasound. She's an 18-year-old female with primary amenorrhea. Her clinical features, she had short stature, webbed neck, and arachnodactyly. By the ultrasound, we can see here a very small dysplastic uterus. We can see here right streak gonads and left streak gonads. This takes us to the part of the algorithm where we don't have any proper testicular tissue or we don't have palpable gonads. Yes, we have a dysplastic uterus, and for the gonads, we have streak gonads. So this is a complete gonadal dysgenesis, Turner syndrome, and she was approved by the chromosomal analysis. To summarize, understanding the importance of the family's need for the sex assignment and clinician needs for reliable diagnostic imaging results will help radiologists participate effectively in the prenatal and postnatal assessment of patients with DSD. Accurate demonstration of the genital anatomy is essential for proper gender assignment and for the treatment of intersexual disorders. Thank you.
Thank you very much, Yasmine. Thank you very much. And now the next lecture will be Dr. Sally Yahya, lecturer of radiodiagnosis in our unit, urogenital unit. And she's going to talk about state of art in imaging of renal transplantation.